including the patient herself and her mother, who is housewife and educated up to higher secondary, presented with chief complaints of diagnosed as congenital heart disease at 2.5 months of age and fatigue on exertion for last 3 years, bluish discoloration of hands and feet for last 2 years.
Yes, go ahead.
History of present illness. My patient, 12 years female child, late preterm 36 weeker, birth weight 2 kg, born of non-consanguineous marriage by normal vaginal delivery at hospital, cried at birth, exclusive breastfed at hospital, discharged on second day of birth. At the age of 2 months, she was suspected for having some congenital heart disease when evaluated for fast breathing, failure to gain weight, and excessive sweating during feeding by local pediatrician. Echo was advised, but it was not done that time.
Yes, go ahead.
Echo was done at 2.5 months of age when for severe pneumonia, she was admitted for the first time. It revealed congenital heart disease in the form of a hole in heart for which some medicines were prescribed and she was under regular follow-up under cardiologist. At that time, she was advised for cardiac surgery. Medicines, she was having similar kind of symptoms and not gaining weight properly. But when surgeon described them regarding surgical risk, family was not agreed to go for surgery in fear of losing the baby, and they opted for continuing conservative management in spite of having counseled by the cardiac team that surgery was only definitive management. In next 5 years, she had multiple episodes of exacerbation of breathing issues, cough, cold, frequent visit to pediatrician and cardiologist, including 2 episodes of admission for probable LRTI requiring IV medications. However, they didn't stop oral medications prescribed by the cardiologist. Her development and intelligence were normal as per mother. Now she reads in class 7, although academically she was a bit slower initially due to frequent cough, cold, breathing issues and needed frequent visit to local pediatrician. She was weaker and less interested in playing in her peer group in school and with local friends also due to always having some breathing problems. After 5 years of age, they noticed the child gradually improved her symptoms and her performance in terms of physical, educational, all were improving. It lasted from around her 5 years of age to 9 age. At that time, she improved academically also in her school. They stopped all the medicines from around her 5.5 years of age. And the child was lost to follow-up since then. However, from around her 9 years of age, they noticed she started having fatigue on exertion. Onset was insidious. Initially, she could go to school 4 kilometers by her bicycle, but she was getting fatigued after cycling 1 to 2 kilometers. She could ride 3 flights of stairs without having any difficulty, but now she was unable to ride even 1 flight of stairs without any fatigue. Gradually, within 1 year, it increased so much that she could not walk more than 100 meters at a stretch, and she was getting tired even during routine household activities. But it was not present during rest. She had to discontinue her school. They consulted local pediatricians for these symptoms, but not relieved on those medications. Around 2 years back, they noticed mild bluish discoloration of hands and feet, initially on exertion, but then it looked to be uniformly bluish in few months. They visited one cardiologist who prescribed them 2 medicines after doing echo and some blood tests. After taking medicines for 4 to 5 months, she improved gradually and she again became able to go to school with her bicycle after 6 months of therapy. Her bluish discoloration also disappeared gradually. Currently, she was on those medications for last 1.5 years. Although for last 1 week, due to some family issues, they stopped medicines. 1 year back, she had some mild cough, cold and fever and was COVID-19 RT-PCR positive along with all her family members and was managed symptomatically. Negative history, no history of bluish discoloration of limbs, lips anytime before these 2 years.
Wait. Now, can you summarize all your positive history findings? Can you summarize all your positive history findings, whatever you have told us?
Ma'am, preterm low birth weight baby
Okay.
with normal vaginal delivery and normal natal and prenatal postnatal history, uh, diagnosed as congenital heart disease when evaluated for fast breathing, increased
At what
sweating
age? At what age?
at 2 months of age,
Okay.
fast breathing, sweating during feeding, and not gaining weight properly.
Okay. Then?
And echo was done at
No,
2.5
I
months.
don't want to. I don't want that. You have already told only the positive points in the history. Somebody diagnosed to have a heart problem at 2.5 months of age due to whatever symptoms. Then the next one.
One episode of pneumonia,
Okay, one episode of pneumonia.
and followed by 2 episodes of query LRTI, for which she
Okay.
needed admission,
Okay, then.
and frequent cough, cold, and breathing issues
Okay.
till 5 years of age.
Okay, then. See,
Then
when we ask you to enumerate your positive findings, we listen to all your history findings. We wanted to just you tell us, which will lead us to some clue. Somebody who is diagnosed to have heart disease at 2.5 months of age, had frequent LRTRs till 2, 3, 4 years. Then she started developing fatigue. So your important symptoms in the fatigue, in the all your history, somebody diagnosed to have heart disease at 2.5 months due to breathlessness and repeated respiratory infections. Then had fatigue for last 3, 4 years, and then had cyanosis. So these are the three important features in your history, and then we want you to really want to know how you collaborate your these particular points in the history to your possible diagnosis. Now somebody develops to breathlessness and have breathing difficulty and had admissions due to LRT at 2.5 months of age. So what are the possible things you think about?
Ma'am, it can be due to shunt lesion, due to congenital heart disease.
What kind of shunt lesions you want?
Left to right shunt lesions.
At what level?
Post tricuspid shunts.
Okay, but then what? Specify. Can you just specify?
VSD, PDA, AP window, AP canal defect.
So cyanotic
Truncus.
disease or acyanotic congenital heart disease only?
So somebody can be even a cyanotic congenital heart defect with excessive
Maybe
pulmonary blood
cyanotic
flow.
or acyanotic.
When somebody asks you this question, so you should say both cyanotic and acyanotic heart defects with excessive pulmonary blood flow can present like this. So now enumerate amongst the acyanotic heart defects, then enumerate about cyanotic heart defects. We want to know both. Both can be possible.
Yes.
So can you just tell what about the acyanotic heart defects which are possible who present at 2.5 months with this kind of symptoms?
Ma'am, VSD, PDA, AP window,
Anything else?
AP canal defect.
Some rare problems? Some rare left to right shunts at this age. You told VSD, you told PDA, AP window, AV septal defects, anything else at left to right shunt at this age. Not very common, but we do see them. Even we do see them a little early, another hint, not even they don't come to 2.5 months, they may be even 4 to 6 weeks.
AV coronary fistula.
Coronary AV fistula, by and large, what is the history of? See, when you utter these kind of words, we jump into something else. Usually, what is the shunt fraction in coronary AV malformations? How much is the
very less, ma'am.
Very less. So usually, how much QPQS you expect in a patient with coronary AV malformations or coronary cameral fistula, whatever you call it as. So, what is the kind of QPQS you expect in coronary AV malformations?
Less than one.
You must have closed some of the AV coronary AV malformations, and you see them. How do they present? How do they present coronary AV malformations? See, if you
Mostly
say
incidentally diagnosed.
So they are incidentally diagnosed. Somebody just listens to some continuous murmur, or somebody just sees that there is a mild cardiomegaly on X-ray test for some unknown reasons, and then they get evaluated. You know, the shunt fraction is somebody has written here is usually not more than 1.5 to 1 unless they are very huge and they present very early. But by and large, the shunts are very small shunts. So usually they won't present at 2 point. Garbody defect, no. Which are the other little rare, unusual defects, but we do see them as a very large left to right shunt. And as I said, they even don't present at 2.5 months. They may present even before 2 months to 4 to 6 weeks. Have you heard of RPA coming from ascending aorta? Pulmonary AV malformation, somebody has written, is very wrong. Pulmonary AV malformations don't present as a large left to right shunts. They present with severe cyanosis. So Malvika have RSOV ruptures also usually you don't see at 2 months and 2.5 months because the history itself is different. They don't present at 2 months. RPA arising from ascending aorta. See, somebody has said TAPVC, we are just talking about all the acyanotic heart defects. So one is the ventricular septal defect at various levels. Then you have a large PDA or a AP window, or you have AV septal defects. Your right pulmonary artery arising from the ascending aorta is a huge shunt. Usually even they don't wait till 2.5 months. They present much earlier because the shunt is so large. As soon as your PVRI comes down, they may present by 4 to 6 weeks as well. Now amongst even truncus arteriosus, huge shunt, present very early by 4 to 6 weeks itself. So amongst the cyanotic heart lesions, who can present at 2.5 months with these symptoms?
Ma'am, TAPVC, truncus, CCTJ, VSD, increased pulmonary flow, TGA, VSD, increased pulmonary flow.
CCTJ, VSD is like a VSD physiology, it's not a different physiology.
DORV, VSD, increased pulmonary flow.
So again, the DORV subaortic VSD will behave like a large VSD. So amongst
TGA, VSD, increased pulmonary flow.
Okay, TJ, VSD. But see, TJ, VSD, again, they may present more with the cyanosis.
Cyanosis.
They will
Here, Manubika, tell us about the admixture physiology, which is normally cannot be picked up. The cyanosis is not picked up by the parents. There appears to be acyanotic heart disease with increased pulmonary blood flow. Those of disease, which can be the differential diagnosis of VSD as well as PDA. Tell us those things. TGA mostly presented with cyanosis, obvious cyanosis. Your case, you haven't uttered about cyanosis in the beginning of your disease. So it appears to be acyanotic. Okay, tell those cases. TAPVC, truncus, and then
Single atrium.
cyanotic heart defects with you have minimum cyanosis. Your oxygen saturations may be around 90%, but you have excessive pulmonary blood flow. So in that situation, even if they are cyanotic heart defects, the cyanosis is very mild. So it's not perceived by the parents and the physicians as well.
Single atrium.
Okay, common atrium. Then it's mainly they are like a mixture lesions, TAPVC, truncus arteriosus, AV septal defects. So those kind of defects can be present at this. One is acyanotic heart disease, one is cyanotic heart disease. Any other lesions who present with this kind of symptoms at 2.5 months? Two and a half months with a respiratory distress, with hospitalization, with pneumonia and all those things. Anything else who can present?
And according to surgeon has told to do the surgery at 2.5 months old baby. So must be a serious kind of thing, na? Tricuspid atresia 1C, increased pulmonary blood flow,
single ventricles, double inlet left ventricle with unrestricted pulmonary blood flow.
Might be PA banding rather than VSD closure, na?
So one is this acyanotic heart disease with excessive pulmonary blood flow, mild cyanosis with excessive pulmonary blood flow. The third is when you have any kind of pathology with your ventricular function as well, You have a ventricular dysfunction secondary to severe coag. They also may present with respiratory distress, with breathing difficulties and hospitalization. And the fourth one is abnormalities of the left AV wall. You may have congenital left AV wall abnormality who will present exactly in the same way. So I think in the examination, you rather than just telling, I think you just categorize them into 1, 2, 3, 4. That's better for your understanding also and our understanding also. And that we know that you have some clarity of your thoughts, whatever you are talking. So these are the possibilities when somebody presents at 2.5 months of age. So you may say that ventricular the way the history goes up, ventricular dysfunction, any lesion associated just with ventricular dysfunction appears little less likely because they may not survive till 12 years of age unless you correct the lesion. Understood?
Yes.
Okay. Now, Maua, anything else you want to ask?
Madam, they are asking why not Al-Kappa? Students are asking.
Even the other one is definitely ventricular dysfunction with definitely Al-Kappa with ventricular dysfunction. Again, as far as an actual history goes, somebody who is surviving till 12 years of age. Sometimes it's difficult. It may be possible if you try to say or postulate that they may develop multiple coronary collateral circulation and they can present, but usually the history is like excessive cry, severe ventricular dysfunction, and unless you correct, somebody again is surviving till 12 years of age.
Plus now appearance of cyanosis.
And then appearance of cyanosis. So you have to get into a lesion which has survived till 12 years of age. Okay. Now, just so you are contemplating any of these lesion, isn't it, Malvika?
Yes, ma'am.
So either any left to right shunt at any levels. Then what happened?
Then the patient developed. Then the patient symptomatically improved from 5 to 9 years of age.
Okay.
So Epstein anomaly is it possible to have Epstein anomaly newborn presentation, then improve, then came again?
See, very less likely, isn't it? Because if it is a neonatal Epstein's, they are very sick.
Yeah.
They are very sick. So as far as the presentation of the Epstein's, if they present in first, second month of life, they are very sick and they don't survive unless you do. And even anything you do, the surgical mortality is also more than 90% if you try to repair the Epstein's very early in the
neonatal. Epstein will have cyanosis in neonatal period, then regression.
So
then
there was no cyanosis. At the beginning, there was no cyanosis.
Yes.
So mostly you are like trying to say something which is as a left to right shunt, maybe a cyanotic or maybe mildly cyanotic, isn't it? Like yes. Why she became better and she has excessive fatigue for last 3-4 years, isn't it?
Yes.
So how do you explain these symptoms?
Ma'am, probably the patient developed, number one, maybe patient developed pulmonary artery hypertension and the shunt became less and the patient improved symptomatically at the cost of pH.
At the cost of pH or at the cost of what? See the patient.
RV hypertrophy.
No. See, patient has pulmonary hypertension since beginning. So when the patient improved at use very appropriate words, patient has pulmonary hypertension since beginning. So why the patient improved?
Patient developed pulmonary vascular obstructive disease gradually.
Patient develops, these are the symptoms of increased pulmonary vascular resistance, isn't it? Either the patient develop pulmonary vascular resistance or patient develop pulmonary artery, the obstruction to the pulmonary circulation. What is this symptom of excessive fatigability? What does it tell you?
She told, ma'am, initially
she told is okay. What does the symptom of excessive fatigability means? What is the hemodynamics behind this excessive fatigability?
Ma'am, with exercise, pulmonary blood flow is decreased.
What does it tell you hemodynamically? What does it tell you? See, if somebody has breathlessness, that tells you it's a pulmonary venous hypertension, or there is a left ventricular dysfunction. What does this fatigability tells you?
It tells that pulmonary vascular.
No. What does this fatigability
disease
tells you? Fatigability basically tells you it's a symptom of low cardiac output. So this fatigability is because of low cardiac output. So how do you now explain all these symptoms? Do you mean
It is there? Means what is happening now?
She's happening now. She is developing fatigue. See, they always remember fatigability is a low cardiac output. Now again the question comes in which underlying heart defects you develop fatigability as a symptom. It's a very specific symptoms, and if you get into the details of the history, many times the parents tell you that she was able to play and then now the child doesn't play, just sits.
Ma'am, any heart failure may develop low cardiac output.
No. There are very specific, very specific lesions they present with low cardiac output.
And pulmonary artery hypertension.
Pulmonary hypertension, it's just not a pulmonary hypertension, it's a increased pulmonary vascular resistance. Then second is if you have a left AV wall regurgitation, you see rheumatic mitral regurgitation, the commonest symptom is excessive fatigability because there is no forward cardiac output. The same thing which happens on the right-sided AV wall regurgitation like Epstein's. When there is a severe right AV wall regurgitation, there is no forward flow into the pulmonary circulation. So this is a excessive fatigability is a very, very typical symptom of either severe left or right AV wall regurgitation, increased pulmonary vascular resistance, and this is actually a very common symptom of pulmonary severe idiopathic pulmonary hypertension with intact ventricular septum when there is no shunt happening. Because when you have a shunt, your cardiac output is maintained actually. Okay.
So Malavika, you are thinking about only pH issues. Is there any possibility of gozolization, so improvement?
Yes, ma'am. It may be
natural history of VSD. So what are the natural histories of VSD?
Ma'am, it can be gastralization of the VSD by forming RBOT muscle bundle, the VSD, causing RBOTO and causing pulmonary RBOT obstruction.
So what if it is more likely, whether there is a pulmonary or RV outflow obstruction is more possible or pulmonary vascular resistance going up is more possible?
So cyanosis, according to you, there is cyanosis, obvious cyanosis. So which one is more likely?
Ma'am, pH is more likely because after giving some medicines, patient improved.
See, he might have been given some vitamin and calcium also, we don't know. So I don't think that is the thing which is more likely. You have some cyanosis. You have this excessive fatigability that again tells you that there is a possibility that your pulmonary vascular resistance is very high. Again, cyanosis can be in both the situations. Cyanosis can be increasing RVOT obstruction also. Cyanosis can be because of your pulmonary vascular resistance going up also. So which is more likely, you feel?
pH, ma'am.
So which are the lesions who get eisenmengerized at the age of 7 or 8? So see, she got better maybe at the age of 4, 5, isn't it? 5, 6. So which are the lesions which are likely to get eisenmengerized at this age, 7, 8?
Ma'am, large VSD, large PDA, AP window, or before that, truncus, TGA VSD within 1 year.
So don't get the TGA VSD into thing that we were discussing. They will more present of like a increasing cyanosis, and they get eisenmengerized by 6 months of age. They don't wait till 5 years of age. TGA VSD because of the cyanosis. TJ, VSD, because of the cyanosis, they get eisenmengerized because you know the pathophysiology of developing eisenmengers in TJ versus just a VSD is quite different. In VSD, you know that there is a oxygenated blood goes into the pulmonary circulation. As compared to that in TJ, the deoxygenated blood also goes into the pulmonary circulation, and therefore in TJ, VSD, they develop eisenmengers quite faster and very earlier as compared to just VSD. So it's a very unlikely thing that somebody develops eisenmengers as 5-6. So usually these are the, even now, previously, you know, we used to always say that at the end of second decade, Paul Wood's all the typical classification, the description, what you used to say, that the age of at the end of second decade, the VSDs get eisenmengerized, the third decade ASDs get eisenmengerized. But we see now VSD getting eisenmengerized at 5-6 years. The large PDA is getting eisenmengerized by 2-3 years of age also. So there is a high possibility that your patient may have a large VSD, PDA, or AP window. Those kind of lesions, which the possibility is, or maybe say septal defects are either, it's basically a large VSD, isn't it? So there is a possibility that they get eisenmengerized much faster. See, by and large, I do not know how to like look into your symptom of excessive fatigability, because excessive fatigability usually tells you that it's a symptom of low cardiac output. And when the pulmonary vascular resistance increases, the low cardiac output is more common when you have an intact ventricular septum, that you have idiopathic pulmonary hypertension. Because when you have a shunt at any level, either a VSD or a PDA, by and large, your cardiac output is maintained at the cost of cyanosis. And therefore, we know that as far as Eisenmenger's is concerned, their long-term histories or outcomes are much better as compared to idiopathic PH, mainly because their cardiac output is maintained at the cost of cyanosis. So usually when you tell like this in the examination point of view, I'm just telling you, because she may be having excessive fatigability, but usually by and large in Eisenmenger's patient, we don't see at this stage, at 7 or 8 years of age, excessive fatigability or a low cardiac output as a symptom, because the cardiac output is maintained. Okay.
So, Malvika, you can proceed for examination.
Oh, yeah. Okay. Sorry, we just took lot of time in the history, but mainly because you need to know how to describe your history, which will lead to you some diagnosis. Okay. So as I see, there is no significant neonate past history, isn't it?
Yes, ma'am.
Okay. Okay, you can just see the summary. I just want to see the summary.
12 years female child, diagnosed as congenital heart disease at 2.5 months of age. When evaluated for pulse breathing, failure to thrive in excessive sweating and 1 episode of pneumonia. After being improved for a few years, again she developed fatigue on exertion for last 3 years, which increased from functional class NYHA 2 to 3 over 1 year, and uniform cyanosis for last 2 years, for which currently she is on therapy for 1.5 years.
Okay. Go for the examination.
Malvika ma'am asked same thing from you, and you were not able to speak. You like these things you remember once you have taken the history, and this was the only line ma'am was asking that time to summarize your history.
Yeah. Okay.
On examination, patient is conscious, alert, oriented, cooperative, weight 43 kg, height 165 centimeter, BMI normal in WHO BMI chart, no pallor, no cyanosis, no clubbing or jaundice, neck glands not palpable, JBP raised 3 centimeter from angle of Lewis, A-wave is prominent, saturation basal 97%, after exercise 96%.
Why do you do after exercise oxygen saturation? What do you expect?
Ma'am, post-exercise desaturation is if there, then pulmonary vascular resistance, if it is high, then the RV cardiac output is gets low.
Why patients with very high pulmonary vascular resistance desaturate after exercise? What I mean to ask you.
They cannot increase the cardiac output due to increased pulmonary vascular resistance during exercise.
Anything else, anybody? What happens to the systemic vascular resistance when somebody exercises?
It falls.
So it falls, then what happens? So more desaturated blood goes into the systemic circulation, isn't it?
Yes, ma'am. More right to left shunt.
Or more right to left shunt. So your pulmonary vascular resistance is very high, systemic vascular resistance decreases, and you have more desaturation, which actually should not. If your PVRI is less, the more blood should go into the pulmonary circulation when you exercise also, because your PVRI has to be less than the SVRI. And therefore they don't desaturate, but if your PVRI is quite high and SVRI is low, basically more desaturated blood goes into the systemic circulation and they desaturated, and that indirectly tells us that the PVRI is very likely to be very high and they may not be operable. Okay, next.
The BMI chart, which is normal.
Okay.
Pulse 84 per minute, regular, normal volume, normal character. Or all peripheral pulses are palpable, no radial or radiofemoral delay. BP 110 by 68, right upper limb, 110 by 70, left upper limb, BP 118, systolic lower limb, temperature 96 degree Fahrenheit, respiratory rate 14 per minute, regular. Cardiovascular system.
One more thing, what did you miss in the general examination? Can you just go back? General examination, just go back once here also. Yeah, here. What did you miss in the general examination?
From head to toe.
Saturation is where did you see the saturation? In this situation, don't you feel that it's very important to see the upper limb and lower limb, both the saturations?
Ma'am, we have seen, I just have not written.
That's what I said, because these things are very important in your examinations. Okay.
This is upper limb saturation or lower limb? What you have written?
Ma'am, both upper limb, lower limb were same.
No, it's okay. You might have taken, but as I said, from the examination
Just
point
to
of view, it's very
put your
important.
point, you can say all four limbs.
Okay.
Inspection and palpation of precordium, no scar, prominent vein visible on precordium, no bulge, symmetrical chest, trachea centrally located, upper border of liver dullness, right fifth intercostal space, mid clavicular line, left side tympanic resonance of stomach, heart, visible impulse in apical area, fifth intercostal space at mid clavicular line, RV type diffuse apex, fifth intercostal space in mid clavicular line. Visible pulsation in left lower sternal border, grade 2 parasternal impulse, well sustained, synchronous with apex, apical impulse continuous with the parasternal impulse, epigastric pulsation present touching tip of the finger, left second intercostal space, S2 palpable.
Okay.
Auscultation. S1 normal, A2 audible, normal, P2 audible in apex, left lower parasternal border, grade 2 by 6.
1 minute. P2 you tell at apex. So usually by and large S1, when you say it's S1 is at the apex, and the P2 always is at in the pulmonary area, isn't it? Munish, is anything different now? Like,
no, means
yeah,
describe heart sound like
sound is
S1,
always
S2,
at
S2,
apex. The
S4
second heart sound is always in the left second intercostal space. So P2 is audible at apex. Do you mean to say that means the P2 is very loud?
Even in apex? Or
No. And then the sounds have to be very perfect. Where is S1? Where is S2? What is happening to the A2, P2? Is there a split? Is there a normal split? It's a phasic split, or you have a second heart sound?
Description of second heart sound carries so much meaning here.
So much of importance. No, this is not right. So S1 is always at the apex. What about the A2? A2 has the S2 has two components, A2 and P2. And P2 is not, you never say P2 audible in apex, you know. P2 is always in the left second intercostal space. And then what is happening? What about the split? Is a single second heart sound, there is a splitting of the second heart sound, is a normal split, is a phasic split, is a fixed split, or you have a single second heart sound. It's very, very, very important, especially in this case, because I'm sure there mustn't be any murmur. So everything is around the sounds.
Ma'am, P2 palpable, constant ejection
Not
click.
Abhi, no, we just don't go into the palpable. We are coming to the auscultation. I want the auscultation findings about the heart sounds. Go to the sounds. Auscultation, just describe your sounds very correctly.
Just forget this slide. Just describe
Just
what you
focus
heard.
on this side. What is S1? What is S2? Whether there is
Ma'am,
any
S1 is
S3?
normal
S1 is normal. Where do you hear the S1?
in apex.
S1 is always at the apex. Where do you hear the S2? What about the A2 and P2 components?
Ma'am, A2 is normal.
A2 is normal. What about the P2? P2 is never at the apex. P2 is always at the left second intercostal space.
Intercostal space.
So what about the P2?
A2 P2 split is hard on
So
inspiration.
P2 is normal intensity or it is loud P2?
P2 is louder than
What about the
A2.
A2 P2 split?
Narrow split.
There is a narrow split, but we are able to hear both the A2 P2, both the sounds, isn't it?
On
That's what you mean to say.
inspiration, both the sounds are hard as
Yes,
separate.
when you say about inspiration, expiration, that means there is a phasic split. Use very, very scientific words. So it's a normal phasic split, do you mean to say? Or the split
No.
is phasic but a narrow split? Or you want to say
Phasic,
it's a
but
second?
narrow split.
So both the components are heard. It's a narrow split. So describe it very correctly. Both the components are heard. P2 is loud. There is a normal split. It's a phasic split, but the split is a short split or a small split. You want to say? Is it?
Yes, ma'am.
What about S3? See,
S3
when you start
not
your
audible.
auscultation, you have to complete your sounds very correctly. There is no S3 and there is no S4. And even if they are negative findings, you have to write in your auscultation findings. Don't get stuck up in auscultation in sounds itself. Because P2 is the most important, the second heart sound is the most important thing in congenital heart defect. I remember Dr. Tandon telling Munish, the only thing which is important in congenital heart defect is the second heart sound.
Yes.
So you have to know, you have to describe it very correctly. And don't say that this is a very gross mistake. That P2 very loud heard in the apex. It never happens. Always the sounds are heard.
Your diagnosis means in this case is all depend on this second heart sound.
Everything is on the second heart sound. So don't make these gross mistakes. Okay, next. And then even if you don't have, because we expect there may be a possibility of a right ventricular third heart sound. So there is no S3, there is no S4. So it's very important to say even if they are not there, the negative findings. Okay, then?
Ma'am, in left second intercostal space, there is one high-pitched blowing crescendo, early dust.
And now you are in the auscultation. And why did you write P2 palpable suddenly? Isn't it? These are auscultation findings. So why did you write P2 palpable here? Left second intercostal space, where is the P2 palpable? These are auscultation findings. And you have a constant ejection.
You wanted to combine palpation and auscultation in this slide, isn't it? You wanted to combine palpation and auscultation.
She did inspection and palpation there. When she combined inspection palpation, she mentioned second heart sound palpable. But here I think by mistake she.
So you should not, okay?
Okay. Again, it's a constant ejection click. You may like to say that this is a pulmonary ejection click, isn't it?
Yes.
So whenever you hear this pulmonary ejection click, by and large, it's such a severe pulmonary vascular resistance that splitting of the second heart sound usually is not possible. So these are some of this retrospectively you have to just see in this, because you are saying here first like A2, P2 are split and there is a phasic split, but you have a constant ejection click. Something doesn't go hand in hand here. So usually when you are explaining about the ejection click, you are telling that your PVRI is really very high. And we usually don't expect a A2P2 splitting which has a phasic split in general in these situations. So be very careful when you explain your findings. Okay. Next. Hello, Malvika. Yeah. Now tell about the murmur. Because sounds here need to be explained in detail and everybody need to know what exactly what you mean to say. Okay, next. Now we are
Left lower parasternal border, grade 2/6 ejection systolic murmur, early peaking, crescendo decrescendo, medium pitched, hard with diaphragm of stetho, increase with expiration and hand grip, radiating towards right lower sternal border. And early diastolic murmur.
Just go back. Just go back. See, when you do the auscultation, it's usually you have to explain. Now, again, you have come to the right second intercostal space. Again, you have come to the sounds. Just usually when you explain in the examination, you have first all the sounds, then the murmur. So it's like that. Now we have come into the murmur. Again, you have come into the other area with the sound. So we expect that when you talk about S1 is at apex, we talk about a second heart sound. A2 is on the right side. B2 is on the left side. S3 is depending upon whether you have a right ventricular S3 or a left ventricular S3. So describe all the sounds first rather than just you are describing according to the areas. That's the way it's done in the examinations. Okay? Okay, just go.
Early diastolic murmur, high pitched blowing decrescendo, early diastolic murmur, breast audible in left second intercostal space, radiating towards left sternal border, increased with inspiration and leaning forward. Respiratory system, thoraco-abdominal type respiration, airway normal, no tachypnea, respiratory rate 14, regular, chest bilateral clear, vesicular breath sound, no added sound, CNS oriented to time-place person, sensory motor autonomic system are normal, JAKs normal, plantar flexor bilateral, no visual blaring, can read paragraph, no focal neurodeficit. GI system, oral cavity, dental hygiene, good oral hygiene, abdomen soft, liver just palpable, liver span 7 cm, no splenomegaly, no ascites, rectal not done. Musculoskeletal system is normal, and other systems normal. Sexual maturity rating, failure ke breast development Tanner stage 4, puberty Tanner stage 3, menarche not started. Provisional diagnosis, situs solitus, livocardia, non-restrictive VSD, severe pulmonary hypertension with component of pulmonary vascular obstructive disease or eisenmenger syndrome on treatment. In sinus rhythm, fatigue, NYHA class 2 on treatment, PH, WHO functional class 2 on treatment, no evidence of pulmonary venous hypertension, congestive heart failure, or infective enteritis.
When you get this finding of early diastolic murmur in the second intercostal space, which of the Eisenmenger's lesion is more likely to be? When you hear in your finding, there is a early diastolic murmur in the left second intercostal space with an ejection click. Amongst all the lesions of ASD, VSD or a PDA which get eisenmengerized, which is the lesion which is more possible with these findings?
PDA.
So we have a ejection click with early diastolic murmur. The more likely diagnosis, I will say it's a PDA which is eisenmengerized. So in your diagnosis, why it has come as a VSD? I'm just telling you about as far as your auscultatory findings is concerned, VSD with Eisenmenger's is much more, you get this murmur of early diastolic murmur of pulmonary regurgitation, which is more often or more common with PDA which gets Eisenmengerized, not with VSD which gets Eisenmengerized. Yeah, agree, Munish? And
yes.
It's always with the PDA which has a long early diastolic murmur in the second intercostal space with a ejection click.
So Malavika,
at the end you may find something else. At the end you may find.
You have taken dual dim saturation because
yes, ma'am. Ma'am, there is no differential no history of any differential cyanosis.
That's okay, but this finding usually you get in a large PDA which is Eisenmengerized than the VSD. Yes. It's a long blowing early diastolic murmur in the pulmonary area. So I would have like in the examination purpose, you should say usually this is the first diagnosis would have been a PDA which is Eisenmengerized, but a differential saturation is not there, which is therefore It may be less likely, but again, if you say VSD, which is eisenmengerized, I will say the pulmonary regurgitation murmur also is very less likely with the VSD eisenmengers.
And if it is VSD eisenmengerized, there is no desaturation. So, like, balance
No,
stays.
but you have to just consider in this situation both the things.
Yeah, both the
So
things.
what are the lesion, what are the differential diagnosis you can exclude from this point of time? What can be excluded? One by one, you have talked about increased pulmonary blood flow, cyanotic congenital heart disease like that of Tomkas. Is it possible? Tomkas is excluded. So
No, ma'am.
ask
These are
what are
acyanotic heart diseases are maybe there. Only will be here. Acyanotic heart disease, VSD, PDA, AP window, AB canal defect. These can be the
post-tricuspid acyanotic congenital heart disease.
post-tricuspid.
And what is your that systolic murmur, ejection systolic murmur in the left intercostal space you have described?
Ma'am, maybe tricuspid regurgitation murmur.
See, tricuspid, again, don't talk a very different thing. Tricuspid regurgitation murmur is never a ejection systolic murmur.
Pansystolic murmur.
So if you want to say it's a tricuspid regurgitation murmur, you have to say it's at the left, third, fourth intercostal space. It's a pansystolic murmur. We are talking about the ejection systolic murmur in the left, second intercostal space. So don't confuse like this.
VSD.
VSD murmur. VSD does the VSD gives the ejection systolic murmur. No, I don't know what murmur, or it may be just, you may say it is just a flow murmur. Say ejection systolic murmurs are just a flow murmurs, and usually the ejection systolic murmurs are the murmurs across the outflow tracts. So this may be just a flow murmur across the outflow tract. You never get a VSD murmur or a tricuspid regurgitation murmur as a ejection systolic murmur. Don't confuse. And see, these are very we as an examiner, as I said, then there is an understanding problem. Ejection systolic murmurs never appear across the VSD, and they are never the regurgitated murmurs. Ejection systolic murmurs, by and large, they are murmurs across the outflow tracts.
So Malavika, VSD murmur is expected right now.
Do you expect a VSD murmur again? So don't make these mistakes in the examinations, And if you want to, therefore, you have mentioned this, that there is a ejection systolic murmur. Sometimes it may be just a flow murmur across the right ventricular outflow tract. We are saying that. Don't say it's a tricuspid regurgitation murmur, because this is not a tricuspid regurgitation murmur.
Right now, shunt murmur is not possible, na? Malavika, have you understood what we are trying to tell you?
Yes, ma'am.
Possible, na? Both ventricular pressure is same right now, na?
Yes, ma'am.
So you only have said, therefore you have to explain it. So if you can't explain, just be very sure whether that murmur is there. Because if you say something, you have to explain that.
So according to your history, there was obvious visible cyanosis, na? The second point of your tube complaint was cyanosis.
Yes, ma'am.
But examination wise, there was no cyanosis. Upper limb, lower limb, no.
Yes, ma'am.
Okay. So you are telling it is improved by medication.
Yes,
Which
ma'am.
medication improve cyanosis so rapidly?
Ma'am, she was given palmosil, 10 mg TDS, and iron folic acid.
Okay. You have an X-ray or a ECG?
Yes, ma'am.
Okay, just describe it.
Ma'am, chest X-ray PAV showing normal exposure and mild rotation, and there is no cardiomegaly. Prominent vascular marking.
The most important is what? What is this? What is this pulmonary artery prominence?
RDPA is enlarged, more than tracheal shadow, and there is peripheral pruning.
Comment on MPA.
MPA shadows.
MPA is enlarged. MPA is
It's
enlarged.
huge.
Hugely
It's
enlarged,
dense.
hugely enlarged MPA, normal cardiothoracic ratio, and hilar prominence and
And
peripheral pruning.
situs is solitus.
Okay. Now, ECG.
Ma'am,
Okay.
12
Tell this ECG what it is exactly. What do you see here? Which is telling you the diagnosis actually.
12 lead ECG, normal standardization, and 25 millimeter per second speed, sinus rhythm, P wave morphology normal, and QRS axis.
What is the PR interval?
PR interval is mildly increased, ma'am.
So
16.
you have widely increased, like there is a PR interval which is like a more than 200 milliseconds, or maybe 200 milliseconds or little more than that. That it's
First
a,
degree heart
there's a
block.
possibility of a first degree heart block.
block.
Then what is the axis?
Left axis deviation is there, ma'am.
Is there a counterclockwise loop?
Counterclockwise loop.
It gives a diagnosis to you now.
Inlet, large inlet VSD.
So now what other things? So, chamber enlargements.
RB hypertrophied. Incomplete RBB is there, and LV force is also high, so LV is also enlarged.
So it tells you about the biventricular biventricular hypertrophy.
Yes, ma'am.
So you have a biventricular hypertrophy, you have a prolonged PR interval, you have a left axis deviation, you have a counterclockwise loop. Does that give you the answer for many things here? So what is a possible diagnosis?
Ma'am, it can be large inlet VSD or AV canal defect.
Okay. Next, you have a echo diagnosis. Echoes.
Yes, ma'am.
Munish, tell us when to stop, huh?
Yeah, we have 5-7 minutes.
Okay. Now just tell us about just quick pictures which are relevant.
It's not playing.
Or just tell us the diagnosis. Okay, we could just go back. There was a 4-chamber. Okay, this tells you. So what is the echo diagnosis?
Next.
Ma'am, 4-chamber view showing predominant left to right shunt.
Cross what?
Across VSD. And mild PR is there. Pan-diastolic. And mean PA pressure is 62 plus RA pressure 3 plus 5, 8, 70. Mean PA pressure is 70. And diastolic PA pressure is 24 plus 3 plus 5, 8, 32.
Okay, now we know about it because we are running short of time, that there is a large inlet VSD, severe PH. What do you want to do for this child?
Ma'am, we have to continue the medication.
First thing, do you want to see the operability, or you just want to, the patient is inoperable at this stage? Because according to you, he was 98% saturation. She didn't have any desaturation on exercise. You have a left to right shunt across the VSD on echo.
And left-sided chamber are more dilated. Is there any AVVR? Left AVVR?
Mild AVVR is there, ma'am.
So what do you want to do? You want to condemn her at this stage that she is inoperable, or you want to do something to see whether the operability is there?
Ma'am, I want to do one CAT study.
So that's what I just asked you. You said you want to continue the medical management. So do you want to condemn her, or you want to do, because according to all your findings, you have to say all these things that you want to do, mainly because her resting saturation is 98%. There is no desaturation after exercise. Then you have complete left to right shunt at ventricular septal defect, and she's some 11-12-year-old girl. So
we will do.
What is the only one thing which is going against that she may be operable amongst whatever things you have showed till now?
Ma'am, two things are there.
Which are the
Split
two?
is audible, clinically split is audible, and LALV is dilated.
But I will say there is no MDM at the apex. And if you see the X-ray chest
X-ray
still,
chest is
actually X-ray chest is still a very, very important tool. If you see many senior surgeons, in general, they say we just go with the X-ray chest. There is no cardiomegaly. There is a peripheral pruning. So those things, there is no MDM at the apex on your clinical examination. So all those things actually go against of our operability, but some of the things go for operability. So in this kind of a situation, you will like to go for a cardiac catheterization to see the operability. That should be your answer. Okay. Hello, are you able to hear?
Yes, ma'am.
Yeah, suppose now couple of quick questions. You do cardiac catheterization, how do you see operability?
Ma'am,
What do you use? What do you
basal
see as
PVR.
basal PVR, okay. How much you take basal PVR as a operability?
Ma'am,
Yes,
less
somebody
than
said EDM. Again, that's a right point. There is already a EDM which goes actually against operability because your PR is very significant. Okay, basal PVR. Then what do you do? How do you see the operability? What are the drugs you use for a PVR testing?
Ma'am, normally we use sildenafil NO study,
What
adenosine
do you use?
study.
Whether you use sildenafil or whether you use nitric oxide or you use both?
For children, small children, we use NO, and for slightly bigger children, we use sildenafil.
Why? Any particular reason? Why don't you use in bigger children also nitric oxide?
They don't tolerate NO.
Don't think because even idiopathic pH in adults we use the nitric oxide. Okay, that may be your center's preference. How much NO you use? I'm sure you must have assisted the cardiac catheterization for operability at your center. So how much nitric oxide you use?
10 up to 10 ppm.
Up to 10 is a very small dose. Usually you have to use minimum 20 ppm to see for operability. Okay, but what is the criteria for a PVR for operability for a large VSD? And anyway, what do you see? What do you see after giving nitric oxide?
Ma'am, PA pressure to fall 50%, at least 50% or 20%, and operability for PVR to decrease up to less than 6.
So less than
Alvika, you can't expect PA pressure to fall.
no, see, usually by giving nitric oxide, your pulmonary artery pressures don't fall significantly.
Can't fall. There is a common big communication between two chambers.
If at all, your diastolics may come down, and because your diastolic comes
PVR
down,
will fall,
PVRI comes
PVR
down
will fall.
because effective. See, for PVRI again, what do you take? How do you calculate PVRI in the cath lab?
Ma'am, mean PA pressure minus LA pressure divided by QP.
So usually what happens is you expect mean PA pressures to come down a little bit, mainly because your diastolic pressures come down. The systolic pressure by and large remain unchanged in these situations.
And LA some
PVR by Q.
rise if there is
PVR
a-
by SVR.
You have a QP which is you become little on the higher side.
Malavika, the X-ray, ECG and echo is the same patients, na?
Yes, ma'am. Yes, ma'am.
X-ray is totally non-operable. Echo-wise,
Yes, ma'am.
is
Yes,
so
ma'am.
dilated, and ECG is biventricular. So
Yes, ma'am.
is it patients, na?
Same patient, ma'am. Same patient.
So maybe this is a kind of a borderline situation where you really decide whether the child is operable, and this situation your cath
And
data.
PVR SVR ratio also, ma'am.
How much PVR SVRI ratio is operable?
Less than 0.3.
Less than 0.3, and PVRI by and large should be less than, it should be less than 6 wood units to make it operable. Okay.
Okay. Good presentation, Alvika, but you need to be like
Little fine tune because now you're appearing for the exams. So you have to be using very correct words so that the examiner should not ask you any other question.
so more case presentation is important. So catch any one of your consultant and start speaking. do case presentation frequently. That is the only answer for these, to avoid these some unintentional mistakes. Okay? And today the attendees were very active. Everybody was writing, so that is, you feel very good. Means everybody is so keenly involved into the discussion. And attendance is always good. Whenever there is case presentation, we have very good attendance in the webinar.
Yeah,
So thank
it's
you,
the
everybody.
experience, Munish.
Yeah.
Yeah, for the case presentation, there is a
Yeah. So usually it goes to 150 now because they are busy in exam or something. So we are around 100. But in case presentations, we always get 150 to 200 attendance. And so very good. Means it's feel happy that so many students are getting benefited.
But these
with
are
the
only like a
exposure to
pediatric
medical field.
cardiology or even the adult cardiology also?
Most likely adult also join because we send the information to them also. Means DNB sent the information to share with the DNB cardiology group. 150, otherwise we can't have from pediatric side.
Okay, yeah, that's okay. So, okay.
Thank you, Mama. Thank you,
Yeah,
ma'am.
thank you.
Thank
Okay.
you. Thank you, everybody. Thank you all attendees for joining.